Hi everyone, welcome again to Dr. Deepa's Learning Lounge. I am Dr. Deepa and today we will go through the cytology series with the first topic, which is molecular testing in gynecological cytology. So we will discuss the HPV biology, the current modalities of testings available, the platforms, the triaging strategies, and what are all the molecular methods that have transformed the cervical cancer screening. To begin with, let's first understand HPV at its biological level and the pathogenesis of what it does to cause a cervical intraepithelial neoplasia. The HPV is a double-stranded DNA virus consisting of about 7,900 base pairs. It is extremely common, in fact, the most widespread sexually transmitted infection globally, with more than 100 HPV subtypes are already detected. These are classified by basically on the basis of the L1 capsid gene sequence. Among these subsets, the high-risk subtypes, which are HPV 16, 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, 59, 66, and 68, have a very strong association with the development of cervical cancer. The core reason HPV causes cervical cancer lies in the action of its oncogenes E6 and E7. If you look at the illustration towards your right, then you can notice that the E7 binds with the RB or retinoblastoma protein, which releases E2F that forces the cell to continue dividing. Simultaneously, the E6 inactivates the P53, which is the cell's main damage control protein. Without the P53 and RB functioning correctly, the cell loses its ability to halt cell cycle, repair the damage, or undergo apoptosis. So because of these set of events, the infected cells accumulate multiple genetic errors that leads to cervical intraepithelial neoplasia and in some cases a carcinoma also. Understanding this biology explains the molecular detection of E6 and E7 transcripts that are highly relevant clinically. So these are the various platforms that are available for HPV testing. We will take one by one in detail in the next table. The ones that are available are Aptima, Cobas, OnClarity, Alinity M. So we will look at what the differences are between these basic platforms of HPV. If you compare the different platforms that are available for HPV testing, you notice that each of these platforms differs in its target method and the ability to subtype the HPV. The first row is the Aptima. The Aptima assay uses the transcription mediated amplification and detects the E6 and E7 RNA. So this gives a highly clinical specificity because it identifies the transcriptionally active infections. The second row is the Cobas and the last is the Alinity. So if you look at the Cobas and the Alinity M, both of these are PCR based platforms that target the L1 region of the viral DNA. So this provides a relatively high risk HPV detection with subtyping of the HPV 16 and 18. OnClarity by BD is another PCR mediated system. However, it detects multiple high risk types individually or in grouped clusters, offering an extended genotyping information. So these differences matter because extended genotyping is important, especially for non-HPV 16-18 infection if that is suspected. Being familiar with the strengths of each of these platforms will help us select most appropriate tests for screening and triaging. High-risk HPV prevalence varies significantly depending on the population that is being screened and the assay that is used. On the slide, you can see that the data from major international trials summarized. So in this whole thing, you can see that individuals with NILM cytology HPV positivity typically ranges between 3 to 10%. This shows that even women with completely normal cytology may still harbor a high-risk HPV infection. In contrast, in the patients with ascocytology have a much higher rate of around 60%. This reinforces that HPV testing plays a pivotal role in ascus patients. Cytology alone does not reliably predict the need of colposcopy. So these numbers give us an insight on the expected positivity and the benchmarks for quality assurance within the cytology laboratories. In the year 2019, there was a revolutionary change in the cervical cancer screening by shifting from a result-based management to a risk-based management. Instead of simply reacting to an individual cytology or HPV result, the new guidelines estimate the patient's immediate and 5-year risk of SIN3 positivity, combining the current and the historical testing data. So these thresholds are crucial. If immediate SIN3 plus is seen, then risk is above 60% and expedited treatment is preferred. Between 25 to 59%, the clinician may still choose whether to have an expedited treatment or follow up with colposcopy. Between a 4 to 24%, colposcopy is always recommended. And if there is below 4%, surveillance intervals are calculated based on the 5-year risk period. So this shift ensures that the women with the higher risk get urgent care, while those at very low risk avoid unnecessary procedures. The guidelines are continuously updated, making it familiar for everybody, including the clinician and the pathologist, and it is very essential for modern practice. In this slide, we explore the molecular principles behind HPV testing. The PCR is more widely used amplification technique. It repeatedly copies the segment of the viral DNA using cycles of heating and cooling and denaturing, annealing and extending the DNA fragments, ultimately generating millions of copies. The NASBA and the TMA are isothermal methods, meaning that they operate at a constant temperature. They target RNA, making them useful for detecting E6 and E7 transcripts. The TMA by the Aptima platform begins by capturing the RNA on magnetic particles, converting it to DNA, amplifying it, and then detecting it by chemiluminescence. The hybrid capture 2, once which was a dominant method, detects the RNA and DNA hybrid using the antibody capture and chemiluminescence technique. Though older, it remains as a benchmark for performance studies. Each of these methods has its own advantages, but the overarching theme is the same. These technologies achieve an extremely high risk sensitivity, which is very crucial for clinical settings. The extended genotyping provides more than just the presence or absence of a HPV. It reveals the type of HPV that is present. HPV 16-18 carry the highest risk of progression to carcinoma, but several other types including 31, 33, 52 and 58 also have significant oncogenic potential. Some assay groups provide just groups for practical purposes, while there are some which give full genotype reporting. So this categorization basically allows the clinician to fine tune the risk stratification and tailor the follow-up. Low risk subtypes like 6 and 11 do not progress into cancer and therefore usually are not targeted for routine screening. Understanding which type is present helps to guide the next step of management, especially in cases where cytology findings are borderline and colposcopy resources are limited. When a woman tests positive for a high risk HPV, we need to determine whether the infection is transient or transforming. This is when a triage tool like P16, Ki67 dual staining is very important, and DNA methylation assays are also very important. The P16 Ki67 dual staining test highlights the cells that are simultaneously expressing the cycle inhibitor P16 and the proliferation marker, which is Ki67. So this abnormal co-expression is a hallmark of a HPV mediated transformation. So once you pick this up, it means you have made your diagnosis. Even a single dual stain cell is considered to be positive. It is that important and that specific. Studies consistently show a dual staining has higher sensitivity than cytology alone for identifying a high-grade lesion. DNA methylation studies such as the FAM19A4 and MIR1242 panel or S5 assay detect the epigenetic changes linked to the SIN3. So these tests may serve as powerful triage tools, especially for primary HPV screening programs. So both these tools help ascertain the risk of unnecessary colposcopies while ensuring a high risk patient are appropriately identified at the early level itself. The HPV testing has several well-established clinical applications, and the most common is the ASCUS triage. So when cytology shows atypical squamous cells of undetermined significance, HPV testing determines whether the woman needs a colposcopy. For women aged 30 and above, HPV testing is used alongside the cytology as a part of co-testing. The double negative result of HPV being negative and LILM cytology confers a very low risk in future for CIN3, allowing extended screening intervals of up to 5 years. The landscape is now shifting towards a primary HPV screening, meaning the screening of the HPV alone without a routine cytology itself. So this approach is endorsed by several international bodies and reflects a higher sensitivity of molecular testing. Less common uses include the test of cure after treatment for high-grade lesions and follow-up after colposcopy in cases of persistent HPV positivity. Many of the modern HPV testing platforms also support the molecular detection of chlamydia trachomatis and Neisseria gonorrhoeae. So this allows laboratories to perform a comprehensive STI screening also, which is a single automated instrument. The residual pap test fluid can be used for all of these tests put together, although it is less sensitive than the dedicated vaginal swabs. The PCR and TMA remain the dominant method. Chlamydia screening is recommended for all sexually active women under 25 or older women with risk factors. Gonorrhea is often co-tested because of co-infection that is very common. These integrated systems increase the efficiency while ensuring some high clinical sensitivity and reproducibility. Some other infections that can be detected in molecular techniques include the infectious vaginitis, whether it is bacterial vaginosis, candida species, trichomonas vaginalis, etc. These also can be detected by molecular methods. PCR-based assays offer higher sensitivity than cytology, especially for trichomonas. And some FDA-approved assays like Aptima Alinity M perform extremely well in these. However, molecular tests may identify the organisms in asymptomatic women also, which complicates the interpretation. For example, Gardnerella may be detected in women without any symptoms, without any clue cells on cytology. HSV can be detected using PCR when clinically indicated. Overall, the molecular detection enhances the diagnostic accuracy but must always be interpreted with some clinical context in picture. So to summarize, the HPV molecular testing has fundamentally reshaped the gynecological cytology. By understanding the underlying biology and choosing appropriate testing platforms, interpreting results based on risk-based algorithms and triaging tools like dual staining and methylation testing, we can deliver a highly accurate cervical cancer prevention. The field continues to evolve continuously, especially in adoption of primary HPV screening and refinement of the follow-up strategies based on personalized risk estimation. So as clinicians or as pathologists or laboratory professionals, staying updated with the latest technique is very essential, and this is essential for providing the best possible patient care. That is why I picked up this topic for today, and I hope you like my videos. So stay tuned to Dr. Deepa's Learning Launch. Follow my LinkedIn pages, my YouTube videos, and my channel, which is www.drddeepaslearninglaunch.com. So it is bye bye from me today. Please stay tuned for more such lectures. Take care. See you.